Hello, and thank you for checking out FirstcallID, How to Do an Infectious Diseases Consultation. My name is Paul Bunt, and I'm a specialist in adult infectious diseases and internal medicine. We'll be spending the next 10 to 15 minutes going over some of the key aspects of the inpatient infectious diseases consultation when asked to see a person living with HIV. If you haven't done so already, please check out our first session on how to do an infectious diseases consultation, which covers a lot of the basics of ID consultations in general. Whereas this session really focuses on the specifics of the evaluation and approach to the assessment of HIV-positive individuals. Lastly, before we move on, just a quick note that this content is for educational purposes only. Please refer to current guidelines and use your professional judgment in your own clinical practice. Now, there are many ways to frame our assessment or our consultation when assessing patients living with HIV, but here is one example of a framework. The key points that we like to highlight. So really establishing a clear understanding of the background history of their HIV infection. When was it diagnosed? What is their treatment history? Are they adherent to the therapy? What has their course been like over the years in terms of complications and potential co-infections? What is their CD4 count and are they undetectable? As well as find out who their HIV provider is. When we focus on the issues related to our consultation, there's three main areas that I like to highlight. The first is there presenting problem related to the HIV, considering opportunistic infections, malignancies, HIV drug-related effects, or the HIV itself? The second point is, are they on appropriate therapy, both antiretroviral therapy and potentially prophylaxis? And third, is there sufficient immunocompromise to warrant a further or broader evaluation for less conspicuous infections? Our physical examination always includes a dermatologic exam, looking in the mouth, and examining for lymphadenopathy. The investigations are very case specific, and we'll highlight a little bit of what can guide us in our investigations. And then from this, we provide our summary and recommendations. In addition to providing recommendations on the evaluation to management of these individuals, an ID consult can also offer some meaningful value simply by showing up as an informed and respectful ally. Taking a moment to see the patient as a person, not just a diagnosis, can help build trust. Many people living with HIV face ongoing challenges beyond the medical, including stigma, marginalization, and often complex psychosocial issues. So acknowledging this, even briefly, can leave a lasting impression and support better care. Now back to the key components of our assessment. And this begins with an understanding of their background history of HIV infection. So approximately when was it diagnosed? And if discernible, when was it acquired? Some of the complications of HIV are related not just to the degree of immunocompromise, but the chronicity of infection. We'll ask about complications and co-infections. We'll assess their current antiretroviral therapy as well as their adherence to it. You may be interested in asking about their prior regimens, although this might not be relevant in the acute setting, but it is helpful to know, especially if you are planning on adjusting their regimen. And in terms of prophylaxis, have they been prescribed it and are they adherent? In terms of the viral load, the number is not as crucial as just knowing, is the person undetectable or not? And usually patients will be aware of this. What is their most recent CD4 count? Right, to get a marker or a sense of what the level of their immune system is functioning at and how concerned we need to be about less common or more opportunistic conditions. I'll admit that a lot of my patients now aren't aware of their exact CD4 count. I think in the sort of older days or previous decades, patients were much more aware of following their CD4 count as a number. Now, when patients are much more likely to be undetectable, virologically suppressed, and clinically stable, we don't focus so much on the exact number for the CD4 count, but often my patients will know that their HIV provider is happy with their CD4 count, which generally means it's within or close to the normal range. And along those lines, we do want to know who is their HIV provider as someone that we can contact if we have any additional questions or concerns about the patient. Now here's the first of the three main components of our evaluation. The first is there presenting problem related to HIV or its management? And people often think primarily of opportunistic infections, which is one of the considerations, but we also need to consider HIV-associated malignancies like lymphomas, HPV-associated cancers, HHV-associated malignancies, for example. We have to consider, could their problem be related to a HIV drug-related toxicity? And this can be difficult if you're not familiar with the medications, but it's important to know that some toxicities are drug-specific, where others are class effects. If you're not sure about this, you can at least consider it and speak to someone with more experience in these medications or a better understanding of what the potential side effects or toxicities are. And in rare situations, it's not the complications to the immune system, but the actual HIV virus itself that can cause complications. So classic examples, HIV-associated nephropathy, pulmonary hypertension, HIV-associated neurocognitive decline. And in general, patients who are HIV positive tend to have a more accelerated aging process in terms of cardiovascular disease as well as some other organs. The next component of our assessment is assessing, is the patient on the appropriate antiretroviral therapy? So in general, has the patient's home medications, have all of their home medications been continued in hospital? And things to be mindful of, sometimes a home-formulated medication that they're taking at home is not available in that exact form in hospital. So you want to make sure they're taking all of the components at the standard dose or the same dose they were taking at home. Often when you look at their medication list from home, you want to double check if all of the medications that they're taking are included, because sometimes HIV medications are provided either through the company or through special access. And so some medication lists might not capture all of the medicines that they are taking at home. In rare situations, we will consider holding the antiretroviral therapy in hospital. And when we do so, we try to hold all components at the same time to prevent partial treatment. And the situations where we consider this, presumed antiretroviral toxicity, or if there's a high suspicion for ARV toxicity, severe end organ failure, if there's an illness that interferes with medication absorption, or if there's presumed non-adherence prior to their admission. And in this situation, I think the idea is that if someone isn't taking their medications reliably at home, giving them their HIV medications for a few days in hospital, only to have them stop taking them when they leave the hospital isn't going to be of benefit to them and increases the risk of drug resistance. Now, there might be situations where a patient would be more amenable to continuing medications afterwards, but that's a conversation you want to have with them at the time, and just to get a sense if they are anticipated to be continuing their medications afterwards. Also, when it comes to managing HIV medications or antiretrovirals, it's a really good practice to liaise with the outpatient HIV provider when you are considering any changes. I think HIV providers tend to be quite particular and almost possessive of their patients and their management, and they want to be involved in these discussions. And often they can be very helpful in helping us choose new regimens if we are going to be making any changes. The third component or third consideration as a part of our consultation relates to whether there is a significant degree of immunocompromise to warrant a broader evaluation for maybe less conspicuous or subclinical infections. And so this really depends on the patient's most recent CD4 count, among other factors. And I'll note here that the CD4 count, when you measure it in acutely ill people, can often be falsely depressed just as an effect of their acute illness. And it might not be a true representation of where their immune system is truly functioning. And so you want to take this into account. Maybe if there's a recent CD4 count before their hospitalization, that might be a more accurate measure of where their immune system is at. And other things to consider, if a person is recently starting on antiretroviral therapy, you're expecting their immune system to have some degree of rebound. And so you might not need to cast as wide of a net for subclinical infections. The other thing that's really important to recognize is, based on the CD4 count, you might be inclined to order an array of tests that might take some time to come back. And so you want to think, is the patient going to be in hospital long enough to get these results back? Or is this something that would be best deferred to the outpatient setting? Sometimes you don't know for sure when their next follow-up will be, and I think it's really case by case how broadly you'll be assessing for these in the acute setting. And when you're thinking about what types of infections you might want to screen for in a patient based on their immunocompromise, here's one of a number of representations of the types of conditions or infections people are at risk for based on their CD4 count. And this is not a comprehensive list, but it's a helpful guide. And the first thing to notice is that at any CD4 count, there are certain infections that are more common in people living with HIV. So invasive pneumococcal infections, reactivation of tuberculosis, herpes viral infections, lymphoma, Kaposi sarcoma, and HPV-associated disease. At or around 200 or below, patients are at increased risk of pneumocystis pneumonia, mucocutaneous candidiasis, and in certain epidemiological sort of settings, coccidioidomycosis. And then under 100, we're of a higher suspicion for things like toxoplasma, cryptococcal disease, and PML. And under 50, classically, we'll be more concerned about CMV disease, disseminated Mycobacterium avium, which can have an array of manifestations, which are often very non-specific, almost I call it the dwindles, so subacute or subjective fevers, weight loss, constitutional symptoms, maybe some GI symptoms. So really not really a localizing infection. And as well as intestinal protozoa, more common at these CD4 counts. And so based on the person's presumed level of immune function, you can order investigations related to these types of infections. Our physical examination of people living with HIV is similar to our assessment of all inpatients, with particular attention paid to a dermatologic examination, just that there are many cutaneous complications of HIV, and also the skin can be a window into other systemic infectious processes. Always looking in the mouth or pharyngeal examination. Most common manifestation or opportunistic condition in people living with HIV is oropharyngeal candidiasis, but you may see other lesions that are more clearly identifiable or diagnosable based on visual inspection, like Kaposi sarcoma, or hairy leukoplakia, herpes simplex, HPV-associated lesions, as well as some other conditions. And then we always include a detailed or complete lymph node examination as well. In terms of the investigations, as I said at the beginning, the breadth and depth of investigations really is case specific. We'd like to see a CD4 count if there's not a recent one available. In our institution, CD4 counts are only available on weekdays and must be run with a CBC at the same time. And again, recognizing that the CD4 count might be falsely depressed in the setting of acute illness. Viral load doesn't need to be ordered for all patients when they're in the inpatient setting. If there's a question about virologic suppression, or if you're worried about the development of drug resistance and you want to order a genotype, then it's a reasonable test. Our microbiological investigations and imaging really depend on, again, their clinical presentation, as well as whether we're evaluating for other opportunistic conditions. And as I said, that is based on their presumed level of immunodeficiency. And again, being mindful about what needs to be done at this moment in the inpatient setting and what can be deferred if it can be referred safely to the outpatient setting. Our summary and recommendations will comment on any further evaluation of the presenting issue, as well as management recommendations. We'll advise on their antiretroviral therapy and whether prophylaxis is indicated, and we'll comment on any additional evaluation for subclinical or opportunistic conditions. So just an example of a statement. So in summary, this is a 45-year-old individual with long-standing, well-controlled HIV without significant immunocompromise. They're presenting with community-acquired pneumonia. We would recommend, first, continue current antibacterial therapy for community-acquired pneumonia, further evaluation if there's a failure to respond to empiric therapy. Second, continue home antiretroviral therapy, specifying the drugs and the dose. And three, based on the most recent CD4 count and virologic suppression, no further workup for HIV-associated complications is warranted at present. And fourth, as a collegial touch, we will liaise, or we would ask you to liaise with our outpatient HIV provider to update them on the patient's admission. As a personal sort of point, I really appreciate if I'm following a patient long-term and they're admitted to the hospitals where I work, or even at another hospital, if I'm made aware of their admission to hospital, it's a nice courtesy, and also it's helpful for me to sort of coordinate when my follow-up will be and if there's any additional things I need to pay attention to when I'm seeing them in follow-up. As I wrap up the summary of the session, so here are the key points again, summarized. There's a few things I want to highlight in addition to this. The first is, if feasible, I personally believe that there's value in ID seeing just about every person living with HIV who's admitted to hospital. Our clinicians' comfort and familiarity with HIV management can vary and understandably decline over time. And ID consultants can offer practical support, clarity, maybe provide some education in a collaborative manner. For the most part, patients will benefit from our involvement in one way or another. And a personal reflection, that caring for people living with HIV has been one of the most meaningful parts of my training and my practice. And there's a key reason I was drawn to infectious diseases as a subspecialty. The cases can be challenging. There's often involving a great degree of clinical complexity. They also invite you to engage with some of the broader social, structural, and historical forces that shape health and healthcare. And that perspective stays with you, and it plays a big role in defining us as ID physicians. Here are some resources of the many that are available. The first is the Guidelines for Prevention and Treatment of Opportunistic Infections in Adults and Adolescents with HIV. This is a long document that basically covers the majority of opportunistic infections, discussing their epidemiology, their diagnosis, prevention, and treatment. It's not something you read front to back, but basically you can look through particular OIs that you're worried about in the given sort of clinical setting or for your own learning and read about them. It's a good way to flesh out your knowledge on the various opportunistic infections. The second is just a resource related to HIV medications. It's the National HIV Curriculum, Adverse Effects of Antiretroviral Medications. Again, a good reference when you are curious if a patient's issues could be related to their antiretroviral therapy as a drug toxicity. So that's all for now. I'm Dr. Paul Bunce, and we want to thank you again for watching. Please share any feedback you have about the session or FirstcallID as a whole. If you find us useful, feel free to share us with a friend. Thank you and take care.